afternoon, everyone, and sorry, we've got a couple of minor tech issues, but we will be fine, and if it fails, we'll find another way around it. So it's great to be here. I am Tista Chakravarty Gannon. I co-lead the outreach team at the GMC, but that's just one of my roles. I also work with survivors of abuse in the sexual assault referral centres, and I'm going to be talking a little bit about I'll show you my journey, but the aim really is for us as a group to think about thinking. So really explore reflection. Yes, as I say, I'll use a story from my journey to explore that with you. And then we'll think about how we act on that thinking. So that ultimately is what reflection can lead to, cultural change. So my first question for you, and I'm not sure if the Slido is working yet, but we can get around this first one with just by using the chat. How do you feel now? You've had some really, really interesting sessions. I know there's a session on a patient journey that you've just come from. So can you just, whilst we're waiting for the Slido, just use the chat to type in one word or a couple of words about how you feel now. And I can see the Slido from my end now, actually, just for our tech colleague, Jack. So I can see it there, but I can see lots and lots of people are typing into the chat right now. Okay. And I can see that there are a couple of other questions as well, and I will certainly try and get to those. Neutral, more motivated to study medicine, lovely, better informed, inspired, fabulous. All right, great. So shattering, that was my first if you will, reflection in healthcare when I got into healthcare. And some of you will have heard a little bit of that if you were at the breakfast panel this morning, but I'll share the detail of why. And I'm going to introduce a patient that I met with and share her story. So this is Talia. Clearly I've changed a number of details for confidentiality, but I'll let you read this. Talia. And this is the stage when I met Talia around about 20 odd years ago now. So she presented at SARC, that's the Sexual Assault Referral Centre. And that was following assault from a partner. Now her partner is unaware of her HIV diagnosis. There is ongoing past violence from this partner as well. And we built a really good rapport with Talia. And of course, we're exploring how we could get her to somewhere safe and improve things for her. But at that juncture, she did not want to go to the police regarding her abuse, didn't want to tell her GP about her HIV diagnosis. And that was because her partner attended the same GP and she was worried that somehow it would get out. So her GP is treating her for clearly day-to-day issues whilst being blind to her wider diagnosis. And she does not want her partner to know about her HIV diagnosis either. So that was the point at which I met Talia. Now, as I learned more, I learned about her history. And her history is that as a teenager, she had reported sexual assault. Now that it took quite a lot of persuading for her, as she told us, because she came from a very, very difficult family situation. Lots of deprivation, very dysfunctional environment, no support at all. So it took some persuading through, it was actually a school nurse, to report. However, the police then said, we can't take this further unless you have parental or guardian presence, which is not true, but that's what she was told. So she didn't go back. Now, through the school nurse, she was referred to group counselling. And at one of those sessions, a group of young people, but at one of those sessions, one of the young men there described her as hot. So she didn't go back. And then she explained to the nurse why she didn't go back. And again, she was re-referred, and it was made clear that she needed a one-to-one form of therapy. And she was referred to a psychiatrist. The psychiatrist on the day that she went in happened to have the wrong notes, which of course was something that was discovered later. Talia didn't know that at the time. He was sat behind a huge desk in a suit, terribly formal, and asked her questions like, do you know your name? Do you remember what date it is? Do you know my name? And she was understandably very thrown, very disconcerted. So she didn't go back. And she gave up then. And do you know what her records said? They said that she hadn't complied with treatment. Patient didn't comply. And that, as I say, is when things started to really, really unravel for Talia. And question for you again, having heard that story, how do you feel? And can I check if we can run the question now? It's the second question. How do you feel now? You should be able to use that on your Slido. And just pause whilst you type in your thoughts. I think some are using the chat, but do use the Slido if you can. Yeah, absolutely. Upset, shocked, disappointed. That was it for me, hearing that. Disappointment, absolute disappointment that we as a system could do this. It's quite, and it's the biggest word on there, shocked. It is absolutely shocking, isn't it? So that is why my first experience, my first reflection in healthcare was so shattering, because back then when Talia first needed help, we could have helped her, the system could have helped her, and we didn't. So let's turn this to reflection now, because some of you may have heard this morning that I was talking about the difference between rumination and reflection. And when this happened, when I first met Talia and learned about her story, I was ruminating. I was upset. I was shocked, rightly so. Those shouldn't be taken away. We should have taken away. We should be, after hearing a story like that. But I didn't know what to do with it. So let's turn to reflection. Reflection. This is a definition that I quite like. I'll just let you read that. And as it says, reflection does have many definitions, but they do all look at informing future action, having sought understanding of self or situations. And that's why I like this definition, because it refers to self, because we reflect to improve what we can do ourselves, but we should also be reflecting on the wider picture, situations where we can affect change. And these are the objectives, really, of reflective practice. Yes, to learn from our experience, but to integrate how we feel, that shock, that disappointment, integrating that into professional work, wider culture. And of course, the link to new and existing knowledge. And I'll come back to Talia, of course, I'm not just going to leave it there, but let's explore how we might do that a little bit more. There are a number of methods of reflection, and one that I really like is rainbow writing, which is using a different colour to write from different perspectives. So you might write from Talia's perspective, you might write from the GP's perspective, you might write from your perspective, having been the person who consulted with Talia, you might write from the police perspective. So it's trying to, it's trying to be in their shoes at the time to understand and unpick what the different feelings and events were. So that's one method of reflecting that can get you thinking. But what I want to focus on really today, and it's a model that when Raj was looking at and colleagues were looking at the log that you've been provided, it's one that we've used in that, and that's Driscoll. That's the what, the so what, and now what model. And again, I'll pause so you can just digest this rather than me read it off the screen to you. So the what, that event, a description of it, and that does not have to be too detailed. The so what is the analysis, your deliberate reflection on it, leading to the analysis of what actually happened. And then from that, we can move to discovery. And that in turn leads to, well, what action? What's our action on that? So the thinking on our thinking leads to acting on our thinking. So that's the idea. And it was that and learning about that that helped me start to heal the fragments in terms of how I was feeling. So let's go back to Talia, and I'll let you know what happened. So first of all, I'm just going to ask you what you think we would need to do next, given this scenario. So I'll just remind you of the scenario there. Very, very difficult situation, and your Talia is in front of you and you are there to help her. But what do we do about those factors? The fact that she doesn't want at this stage to report her abuse, that she doesn't want her GP to know about her diagnosis, and that she doesn't want her partner to know about her diagnosis either. What can we do about that? So with that in mind, I'm going to move to our first polling question. So can we launch that, please? Fabulous. I can see that is up there. So take your votes. What do you think we have to do? Do you have to disclose about the domestic violence to the police or social care? Take your votes. Give it a few more moments. And if we've got enough votes in, shall we close the voting? Nope. There we go. Right, brilliant. Now, I have to say, I use these polls in teaching with experienced doctors, medical students, so I'll let you know what kind of answers that we get from them. But the majority, to be clear, have it right. And I'll come back and explain all of that in a moment. But yes, the majority have it right. No, you don't have to. So next question and next poll, please. You are the person who's seeing her in the sexual health clinic or in the sexual assault referral centre. Do we have to disclose her HIV status to her GP? Sorry, Gun is sexual health clinician. That's one of the things in healthcare. Far too many acronyms, and I'm sorry. I am very much guilty of using those as well. Again, I will give you a few moments. And if we have enough responses, can we see the results? Brilliant, interesting. Okay, so we've got a bit of a mix here. You actually don't have to. And I'll explain that one now. So the reason you don't have to is because GPs, like all other healthcare professionals, so nurse colleagues, phlebotomists, etc., have to use standard precautions, universal precautions such as double gloving and things like that. And that is because you might have a Talia who does not know her bloodborne virus status, whether it's HIV or Hep C or whatever it might be. So you have to assume any patient may have a bloodborne virus. So that's one part of it. The other part of it is that, well, we'll come back to the other part. So one part is we know that healthcare professionals are protected, and we'll come back to the other part. But to be clear, just because you don't have to disclose your HIV status to a GP, that doesn't mean you shouldn't explore other things. And I'll explain what we did in this situation and many other situations with many other patients in a similar scenario. So my final question for you in terms of the ethicals that we've got here. So you have spent time counselling Talia, explaining that she does need to tell her partner, that you can help her with that you can arrange for anonymous notification, but she's terrified. She thinks that he will assume that if he is positive, that it's her fault, and she's terrified that it will lead to an escalation of violence from him. And she's adamant that she does not think that he can be told, even if it is anonymously. Now, there are all kinds of vagaries to consider here because we don't know how Talia contracted HIV. It could have been from her partner, etc. But Talia's position is, this time he might kill me. If we get into an argument about this time he might kill me. So with that in mind, can we take a vote on that final question? Do you have to arrange partner notification? And I can see the votes are coming in. I'll give it a few more moments. We spend hours amongst experienced colleagues discussing situations like this? And I'm giving you a few minutes to make a decision without the background. Okay, we've got quite a few respondents now. Can we have a look at the results, please? Interesting, interesting. And can I just say, well done, because the majority of you have it. The language of the question is, must you? Do you have to do it? No, you don't. And now I'm going to explore the why with you. So when it comes to sharing information, there are a number of things that we look at. We look at, you can put it into a mnemonic clap, which is slightly comical when you're talking about sexual health, but I'll leave that to one side. And that is consent. Have you got consent? In this case, clearly we haven't. Does the law require you to share information? In this case, no. There is no statute. There is nothing written in law that compels you to breach confidentiality in this instance, and there isn't a judge-ordered scenario here either. So that leaves you with a final element of that mnemonic, and that's public interest. Is it in the public interest? So that's where it gets more complex. So this is a really, when it comes to thinking about confidentiality, I've drawn this from our ethical standards on confidentiality, which applies to all healthcare because it's rooted in the wider ethical framework and the law. So very, very useful to just remember this when you're thinking about whether or not you can share information. Consent, law, public interest. But let's explore that public interest bit, because I have to say in most scenarios, there isn't clear-cut law on this. So without consent, you are always left with public interest decision-making as a professional. So what does that look like? Well, bringing it back to Talia, in her case, you are weighing, first of all, two things. You're weighing the benefits to an individual or wider society of disclosing that information. So in this case, it would be her partner, because there is a benefit to him, or wider society, because they may both be in other sexual relationships, for example. And you're weighing that versus the harm to Talia. As we've said, this time it might really result in an escalation of violence. So those are two things that you're weighing. There is a third that goes on the scales that you must consider when making a public interest decision. And that is the public interest in a confidential medical service. So to explain that a little more, and this is why, going back to the GP question, this is one of the reasons that you don't have to disclose to other healthcare professionals when you are working with a patient, if that patient is adamant. So the public interest in having a confidential medical service can often outweigh the other considerations. For example, if it becomes, if a service, whether that is a GP service, whether that is a sexual assault referral centre, whether that is a sexual health centre, gets a reputation for being leaky with confidential information, then patients might stop presenting, might stop coming and accessing that service altogether. And that is potentially a greater harm, because at least with the confidentiality that we have in sexual assault referral centres, at least Talia, at least patients like Talia come in. It's hard enough as it is, but if it gets out there that actually they say it's confidential, but then they breach your confidentiality anyway, and people stop presenting, that's going to be much worse for wider population health. So that's why this element is so important when it comes to public interest. And historically, going to the specific GP question, whilst GPs absolutely have the same duty of confidentiality, during the 80s and 90s, there were a lot of patients with HIV who were worried about information getting out in small communities, and therefore services were built so that they could have absolute confidence, so that they would get treated. Now, with all that in mind, it doesn't necessarily make your decision easy. And the way that I like to look at it is every situation has different factors that you're weighing. So let's say that there is a child in Talia's household. Given the domestic violence, that changes the balance of the scale significantly. And from a safeguarding point of view, you'd need to act there. Let's say that the relationship is one where there is low risk sexual activity. That changes the balance. Let's say that Talia had never been lost to follow-up and her viral load is 0. That changes the balance significantly. And I'll explain what we did, because deciding in the moment with something like this, it's not an emergency situation. You've got time. And when you enter the profession, whichever healthcare profession it is, I always say this, always get a sense check from another experienced colleague. These are not decisions that you have to make alone. And in fact, in addition to colleagues that you can get a sense check with, there's also Defence Union, 24-hour telephone lines. There are ethics helplines, etc. in hospital trusts. So there's a lot available. We have ethics support as well. So that's one thing to bear in mind, but I'll share what we did. So we worked as a multidisciplinary team. And we explained to Talia that in order to be able to give her the best possible treatment, her GP does need to know about her HIV diagnosis. She was very uncomfortable, so we suggested, well, would you be comfortable with another GP that is away from your partner? And that's what she did. In that multidisciplinary teamwork, we said, Talia, I'm really worried about you. I've got a friend who works in it wasn't called the safeguarding team then, but who works in another team, and she is really experienced in helping women who are experiencing what you're experiencing. And I'd be I feel a lot more comfortable, because I'm so worried about you, if you just had a chat with her. So that kind of conversation, that kind of approach is a lot less frightening to someone like Talia, and that's multidisciplinary team working. So that involves safeguarding colleagues, and they were able to persuade her to start accessing some services, such as a voluntary drop-in coffee morning thing that was in the area, and she started this women's group. She started going to that. And that started to build her safety network. And eventually we got her into the safe house. And that meant that we were in a place where we could arrange partner notification. And that was all through working with system partners. There was a next step as well, more widely working with system partners. And that was tackling all of the problems that led Talia to where she was in her journey when we met her. So one of the things that we did, we met with the local police, that there is a network around safeguarding, and we met with the local police, the Crown Prosecution Service, GPs, to explore how we can do better. Because albeit this was much later, she's no longer in a team, she's, well into adulthood, the system still wasn't working. There weren't safety nets in place, and there still aren't in many places, but it's improved a great deal in our local area. Through that joint working, we were able to make significant improvements. So that, coming back to reflection, is the value of reflection for me. Yes, it's about self-learning, but it can really make a difference to systems as well. And just thinking about that in a slightly tangential way, I'm going to bring up an image on screen now, and I'm going to give you 10 seconds to identify the mistake on the slide. And this time, if you revert to the chat, apologies, rather than Slido, and just type in as soon as you think you see the mistake. Right, 10 seconds. Yeah, brilliant. We just had 3 seconds left, and yeah, a few of you have spotted it now. Brilliant. To those, can you find the mistake? And this is an interesting one to run in a room, because you'll find half the room get it very quickly and half don't. And it's somewhat analogous to working in a very, very pressurized system where you have so much going on. And in that scenario, it can be easy to miss small things. And we hear a lot of the time that frontline service delivery, frontline patient care in this incredibly busy service, even pre-pandemic, that has got to take precedence. Well, yes, I understand and sympathise with that, of course. But if you don't have the space to think, you will burn out. If you don't have the space to think, nothing will ever change. And this is what reflection can do for us. So that's one example of what reflection can do. And here are just a few others from practice, from those I've worked with. Wrong lens insertion in the eye, reflecting on that, learn, not blame, led to a new process. Incorrect insertion of a nasogastric tube, a feeding tube, led to a new process. A patient complaint because of how it was, how busy it was on the wards, led to, in a particular hospital, a consultant-led service and twice daily ward rounds. And a particularly fraught end-of-life care family disagreement that I remember, it was all absolutely awful, that no discussion had happened until it was far too late, and the patient had a few days left. Daughter flies in from overseas and disagrees with other daughter, all horrible, not at all dignified for this man at the end of his life. And that one of the doctors working with him was so horrified by it, she started an improvement pathway that led to better advanced care planning in the community before it gets to that stage. So this was all reflection. Reflective practice also helps well-being. So my next poll question for you on Slido, what percentage of doctors, because I work at the GMC as well, that's where I have more data around doctors specifically, but what percentage of doctors do you think reported that the pandemic during the spring last year, so that first wave, impacted negatively on their well-being? Just give it a few more moments. And if we could see the results, please. Okay, bit of a mix that we're seeing here. It was actually, an early report said 32% and a later report said 45%. And whether we're talking about a third of our profession, because this was a pretty academically robust study and sample size. So whether we're talking a third or whether we're talking 45%, nearly half, that is not surprising, but nonetheless, shocking. And practicing in this kind of environment when you are not, when it's having this kind of impact on you, it can lead to something called moral injury. And I just want to share a reflective exercise that I use sometimes around well-being. And that is starting with my values. So what values do I want to display when I'm in work? Wider ethical thinking, yes, but also I want to display empathy. I want to be reliable. I want to be positive. I want to make a difference. Nothing particularly shocking, nothing particularly surprising there, I don't think. But what do I feel when my environment doesn't let me do that? And this goes back to what many of you saying in your earlier reflections after we heard Talia's story. And when you're working at odds with your values, when you can't make a difference, then this is how I work anyway. I don't communicate effectively. I deprioritize those areas where I could make a real difference, where I could make a change and just get on with it, if you know what I mean. And I take things home a lot more when I'm stressed than when I'm not. But if I can work within my values, then I'm being a lot more creative. I'm looking at QI, quality improvement, and I'm collaborating much, much better. And that approach can lead to, we call it moral growth, but the idea is that it is linked to reflecting. If you cannot live your values, then you are going to need help. You are going to need support because you are going to burn out. So that's it, really. That's my thinking on reflection. Whether you use it for your learning journey, what you hear today, use it for that, but then use it in practice for system improvement as well. It can make such a big difference. So that's it. We've got a few moments for questions, and I will scan the questions that have been coming in as well. I know a few have, so feel free to type in more, and I'll get through what I can. But also, you can see my Twitter handle on there. I'm very happy for you to get in touch that way as well. Let me just scan the other questions. So I know there was a question earlier on, slightly unrelated, as you say, but I think incredibly valid. What are some of the biggest issues with medicine in general? Right now, in the UK context, it is the pressure. And when I say right now, let me attenuate that slightly. Even before the pandemic, workload is a huge issue. And that is known. So there is lots and lots of work being done to tackle that. If you had asked me in 2016, I would have said something like, it's known. We've been talking about it for a long time. There are pockets of really good practice. But since about 2019, yes, there's been clearly work has been affected by the pandemic, but since about 2019, there was a real critical mass building around improving issues around those pressures. And there's a report that you might be interested in, which we commissioned back in 2019, called Caring for Doctors, Caring for Patients. And whilst it it focuses in on doctors, given that it's a general medical council. It applies more broadly as well. And that demonstrates the things that can be done to improve autonomy for doctors, to improve belonging, to improve people being allowed to be competent because their environment lets them. And it does show not just pockets of good practice, but a wealth of good practice that we can all learn from. So I'd say that that's the biggest issue. There are, of course, other issues as well. But as you'll see from the conference, there is a huge amount of opportunity ahead through technology, learning ahead as we learn more about inequalities. I'm speaking tomorrow about healthcare inequalities. And again, a few years ago, I would have said, we're just talking about it. It's rhetoric. We're not doing anything as a system. Now, I finally think we are. Okay. So let me scroll through the questions. Okay. Another question, how do you find out whether a service is leaky with confidential information? It would be in the press. It might be the local press, etc. I can think of a few instances where that has happened, confidential patient data being shared and things like that. These days, what is perhaps a little bit harder to track is social media, but organisations need to get better at seeing what sentiment. You can run sentiment analysis, and not every organisation does it, but they should. So that's where I would go. And I think I can see some of the questions were about Talia's scenario, which I answered whilst we were talking through the scenario. I don't know whether the partner was actually arrested. It was referred to the police eventually, but don't know what happened. I just know that Talia was safe ultimately and away from him. In terms of GMC, I see, just as we have 1 minute, I see a question on discrimination. So I'm doing a talk that will go into that a little bit more tomorrow. One of the big problems in the talk about health inequalities, one of the big problems that we have is that we receive disproportionate referral of minority ethnic doctors to the GMC. And minority ethnic doctors are twice as likely to be referred to us than white doctors. And that means that when it comes to fitness to practice, minority ethnic doctors are much more likely to be in the sharp end of fitness to practice, because once we have a referral in, then we have a referral in. We have to deal with it. There is a lot of work underway around that, because back in 2014, when we were sharing the data and saying, look, there is a problem here, to comparatively, proportionately, too many Black, minority, Asian and minority ethnic doctors being referred to us. We were saying that then, but actually what we need to do is do more than say it and work with partners to stop it. So there are some targets around addressing that now. It's going to be a challenge because we can't control what comes in to us. We can influence it, however, by working closely with, let's say, the hospital trusts who are making those referrals. So this is an in-depth issue that I'm really, really happy to discuss, and I will be doing more tomorrow. But a recent ruling that was a little bit flawed highlights exactly what I've just said. It highlights that we get too many referrals in, but we can't stop them from coming in. So now, I'm hopeful that by working with the NHS Workforce Race Equality Standard, we will be able to do that. And if you look at the Workforce Race Equality Standard, there's also a lot of worrying but important information available there. So I do think that we are now in a place where the NHS, it's what I was saying earlier, a few years ago I would have said rhetoric. But now I'm seeing a real change in people wanting to tackle these issues, whether it's healthcare inequalities for minority ethnic people, whether it's for women, etc. Okay. Right, and we are a little bit over time. There's a query about going back to the 4-table slide. So I'll just do that, and then I think we probably need to wrap up. There you go. I will. You can take your screenshots of that if that's helpful. But thank you very much. It's a pleasure to have spoken today. I'm sorry that we can't actually speak face to face, but I hope that was useful, and I hope to see you at some of the other sessions later on. Thanks very much.